Dear colleagues, dear friends, my name is Pippo Simona and I am the editor of the Electronic Ophthalmology Notebooks. The preparation of this video has been demanding, at times even challenging, but now we are approaching the finish line and it is a real pleasure for me to introduce this program today. I am especially happy to present it together with three distinguished experts and dear friends. Professor Gabriella Di Salvo from Birmingham, UK, PD Dr. Moreno Monghini from the Ophthalmic Center in Lugano, Switzerland, and Professor Maurizio Battaglia Parodi from San Raffaele University Hospital in Milan, Italy. For many ophthalmologists who are not subspecialists in inherited retinal diseases, approaching this condition can generate a certain sense of caution. Their complexity is real, their variability is considerable, and this is particularly true when we consider neovascularization in inherited degenerative disorders. In fact, the neovascular membranes associated with these diseases often behave differently. They may evolve differently, and they frequently require treatment strategies that are not identical to those used in more conventional forms of neovascular diseases. Understanding this difference is not only a theoretical matter, it is essential for accurate diagnosis. It is crucial for appropriate management, and ultimately, it is fundamental for better patient care. I therefore leave you now in very capable hands with the hope that this video will offer new insight and perhaps a fresh perspective within the broader field of retinal neovascularization. The floor to the experts.
Good morning, my name is Dr. Gabriella Di Salvo. I am a consultant ophthalmologist at the University Hospital in Southampton and honorary clinical senior lecturer at the University of Southampton. It is my pleasure to introduce you this course on inherited retinal dystrophies organized by Dr. Simona, a dearest friend of mine. During this course, we will see Dr. Moreno Monghini discussing this challenging chapter on inherited retinal dystrophies complicated by macular neovascularizations. Macular neovascularization is a difficult topic to address, but the correct approach will allow their treatment, and at this time being, it will be with anti-VEGF. This type of macular neovascularization, nevertheless, have a very unpredictable behavior requiring lifelong follow-up and treatment. It is possible that in the future, both inherited retinal dystrophies and complicated by the macular neovascularization will be treated by genetic treatment, and we will see on this topic also the view from Professor Battaglia Parodi, who will follow Dr. Monghini's presentation. I would like to invite you to enjoy the course and join me to congratulate with Dr. Simona for this amazing faculty and brilliant idea. Thank you very much, and bye.
Pippo, thank you so much for the invitation. It's quite tough to going after you, obviously, after having given such a good presentation, and congratulations on such a good meeting. So, Pippo asked me to speak about macular neovascularization in macular dystrophies. I've just increased the topic just a little bit, and I'll be talking a bit more general on inherited retinal diseases. So, Francesco told me that Pippo was just nervous, so it seems that I'm nervous as well. We have different types of macular neovascularization in inherited retinal diseases. We have the group of AMD phenocopies. Next, Francesco. Then we have the group of pattern and vitelliform dystrophies. And next, we do have more generalized dystrophies that can lead to macular neovascularizations, such as enhanced Ascon syndrome or choroideremia. So let's first look at the AMD phenocopies. Next slide, please. Here we have three major diseases that belong to the AMD phenocopies. We have malattia leventinese, we do have source B macular dystrophy, quite rare, and LORD, late onset retinal dystrophy. So let's first look at malattia leventinese, which being almost in the Leventina Valley, obviously makes sense. So malattia leventinese, Francesco, there's a lot of clicking here, sorry. So typically presents a bit earlier than the typical age-related macular degeneration patient. They might be symptomatic around the 4th to 5th decade of life. And then when they get older, into the 70s, they typically exhibit from geographic atrophy, loss of visual acuity. There is not only GA can lead to loss of vision, but MNV as well. Next. So what we do see clinically is that the mutant and misfolded EFEMP1 protein accumulates between the RPE and Bruch's membrane. And if you click, again, Francesco, you can see on the slides of these are patients from us, from the Ospedale Italiano. You can see how massive that accumulation of confluent drusen material is. And if I may guide your attention to the bottom slide, this is a patient that actually already has GA. And in contrast to patients with AMD, typically all that material that had accumulated still resides and still can be appreciated. So that accumulation of drusen typically leads to complement C3 activation, and that generalized RPE and choroidal abnormality then promote MNV. And certainly, next click, Francesco, for MNV, we can use anti-VEGF. And I think I have to apologize now. In the introduction of my talk, I actually had an intro slide that wasn't shown. But basically, maybe Francesco, you can go back. We can go back to the very first slide. We can use this example to quickly explain why it was such a good idea by people to ask me to talk about this, because for macular neovascularization in IRD, we do not have level 3 evidence, certainly because all the cases are really rare. And we also have to keep in mind that these patients, despite being quite rare, they might still pop up in our practices, in our clinics. And as such, it was a really good idea to give this a talk. So let's jump to the next AMD phenocopy. So we've seen malattia leventinese that typically leads to geographic atrophy, but can also show MNV, and certainly we can use anti-VEGF if polypoidal lesions show up. Maybe PDT may also be considered. So the next one, source B macular dystrophy, is quite rare. It is also an autosomal dominant related disease that has mutations in TIMP3, a metalloproteinase of the extracellular tissue. And similar to malattia leventinese, patients get symptomatic around the 4th to 5th decade of life. But here, in contrast to malattia leventinese, MNV is a big problem. And if you just click a few times, typically M and V is also seen bilaterally, and the defect in the TIMP3 gene leads to an accumulation, a broad accumulation and separation of Bruch's membrane from the RPE. You can appreciate that well in the OCT. And why is it called an AMD phenocopy? Because it also may show reticular pseudodrusen. Next slide. Here you see a case, a 43-year-old patient of ours that has bilateral CMV, and a big problem is that these patients typically lead to an aggressive MNV formation, a bit like the fibrotic cases that were shown earlier in this session. Let's go to the third AMD phenocopy, late onset retinal dystrophy. These, in contrast to malattie leventinese and Sorsby, may present differently. They may show up and say that they struggle at night. They have a nyctalopia and are typically a bit older, so right into that range of your AMD patients. Why is it also considered an AMD phenocopy? You can see it in the picture that will pop up here, and that's because it can show these yellow-white subretinal deposits peripheral to the macula, and also reticular pseudodrusen. These patients may also exhibit macular neovascularization, and being right into that age of AMD, it is good to just keep it in the back of our mind. Interestingly, for all of us that also still use the slit lamp to look at the patients, LORD comes with a unique anterior segment feature. And if you dilate these patients well, you'll see that it typically has zonules that insert quite and much more anteriorly than were typically used. Okay, so let's go. Here is a nice example. I don't have a LORD patient myself, so I asked Gabriela De Salvo, an Italian medical retina specialist in the UK, and she was so kind to share this case with us, an MNV case, a bilateral case of LORD. You can appreciate in the OCT-B scans, if you were just to see this scan, probably most of us would say it's an AMD that has some fibrosis and has some other retinal tubulations. So it is important to combine the multimodal imaging. Okay, so let's now look at pattern and vitelliform dystrophies. Pattern dystrophies are much, much more frequent than your AMD phenocopies. Next, Francesco. So the most common gene, one of the most common genes that we encounter in inherited retinal diseases is PRPH2, and I'll talk about that shortly. But there's also other pattern dystrophies / vitelliform dystrophies, ABCA4. So probably all of you might say, okay, what is he talking about? ABCA4 leads to geographic atrophy, but not only. We have the BES1 associated dystrophies, and then ABC6, which is pseudoxanthoma elasticum. So let's look at ABCA4, or the Stargardt disease. We know patients are young. It's the most common IRD that we have, a prevalence of around 1 in 3,000, and it's an autosomal recessive disease. The allele frequency for an ABCA4 variant in general population is 1 in 25. So if I'm counting here, probably there's at least 1 or 2 that carry a variant in ABCA4. So ABCA4, Francesco, click a bit, leads to geographic atrophy, but not only, and especially, keep in mind, especially in those maybe milder forms that have a foveal sparing phenotype that may present a bit later, MNV may be a reason for a visual drop. And here, anti-VEGF has been used in the past. Here a publication from Fred Chen from the Lions Eye Institute in Perth, where you can see that you can appreciate in on the top image the neovascularization. They injected that patient, but then subsequently in that area developed atrophy. So that's a bit one of the concerns in MNV associated with ABCA4. In Battaglia Parodi also had done quite a bit work on Lucentis and ABCA4. So next, let's look at the bestrophinopathies. So the bestrophinopathies, we all might still remember very well BEST1, which is one of the most common let's say morbus BEST, the BEST vitelliform macular dystrophy is one of the most common macular dystrophy. It is inherited autosomal dominant. However, not only autosomal dominant diseases in BEST1 can lead to a phenotype, there's also the so-called null phenotype. BEST1 may also be inherited autosomal recessive, which then leads to the so-called bestrophinopathy. On the right-hand side, you can see images, again, from Battaglia Parodi, which delineate well the different stages of BEST vitelliform macular dystrophy that we all still remember from the vitelliform stage. Then we have the egg yolk phenomenon going into the vitelliruptive stage, and then GA. It is now, however, believed or understood through the application of multimodal imaging, especially OCT angiography, that BVMD is or may be accompanied by all types of MNV. And in fact, it is evidence lets us believe that most probably stages 2 and 3 go along with an exudative membrane that we had not seen before, where the later stages represent non-exudative stages of MNV. So you can click again here in this vitelliform macular dystrophy. It is important to nowadays combine multimodal imaging, and if you do have a patient with BEST-related IRD, just make sure he gets an OCT angiography. And that is also highlighted by the case that I have seen in Luzerne. This is a 22-year-old male that shows a homozygous missense mutation in BEST1 and reveals a so-called bestrophinopathy. Here, initially, I was only looking at the OCT scan, and obviously, you kind of think, okay, there's this PED, there's a bit of subretinal fluid. It is typical for BEST. However, by doing then an OCT angiography, we could detect type 1 membrane. And again, there's not a lot of evidence that tells us should we treat these patients or not. We've actually treated this patient just recently, so unfortunately I don't have a follow-up. Okay, so let's look at the most common, basically one of the most common genes that we all see in IRD, PRPH2. PRPH2 typically is inherited in an autosomal dominant fashion and leads to the so-called pattern dystrophies. PRPH2 encodes for a protein that actually has an important role in the disc morphogenesis and can lead to all these kinds of phenotypes that are listed here, even RP or Leber congenital amaurosis. Francesco, next slide. Here I'm showing you a slide that can actually be called butterfly pattern dystrophy. It's a 51-year-old female, and most certainly she's within that range of AMD. And in these cases, just keep in mind, it wasn't true for her, but just keep in mind in about 5 to 18%, you may find an MNV. Okay, let's look at yeah, again here publication that I have shown earlier. It's actually a really nice review on IRD-associated MNV that actually shows an MNV associated with PRPH2. So let's look at pseudoxanthoma elasticum, ABCC6, autosomal recessive, typically involves a pathologic mineralization at the level of your skin, vessels, affects the heart, and your eyes. And it goes along with calcifications of the Brooks membrane that then lead to breaks, which we all know that we all call angioid streaks, as you can see here. And pseudoxanthoma elasticum, along with other entities like Ehlers-Danlos or sickle cell anemia that may cause angioid streaks, can lead to very aggressive macular neovascularizations. And all of you who work in medical retina clinics, you know how tough it is to treat these patients. And as seen in the picture of a patient of ours, a 48-year-old male, you can see that typically it may lead to multifocal MNV at the posterior pole that bleed. All right, so let's look at the last group of IRDs that are very rare, but just for educational purposes. One is enhanced as Cone syndrome, quite rare. It actually is a developmental disorder. These patients have mutations in a nuclear receptor, the NR2E3, that actually is involved in transcription. And due to that mutation, it basically leads, instead of having rod photoreceptor developed, they all develop into S cones. So these patients typically have an early onset nyctalopia and may present a phenotype that is quite characteristic along the vascular arcades. You can see these nummular pigmentations, you can see these whitish spots, and they typically have a macular schisis. But eventually they develop subretinal fibrosis, and only recently it was understood that this subretinal fibrosis is actually associated with an MNV. So an entity to just keep in mind. Seldom, I only have one of these patients in my IRD clinic. The next one is also you can jump to the next one, a rare disease. The prevalence is about 1 in 50,000, choroideremia. It has recently gained a bit more interest due to various gene therapy trials that had been ongoing or are still ongoing. And it involves the choroideremia gene, which encodes for a protein called REP1 and is basically involved in intracellular trafficking, so-called prenulation, and phagocytosis of shed outer segments. And we all know how the phenotype looks. Basically, you can look at the bare sclera. So initially in these patients, the RPE degenerates, followed by retinal and choroidal degeneration. However, one of the distinctive features of choroideremia is that these patients retain good vision until quite late in life. They have like cones that survive for quite a long time. And they typically exhibit a shagged and pattern of shortwave autofluorescence. It's quite unique for the disease. And it can also be seen in female carrier if they have a so-called male pattern disease. This is a 73-year-old female from our department. She was actually sent from a colleague here in Bellinzona, so possibly she's even from Bellinzona. And the unique feature here is that similar to myopia, they can also develop CNV, and that might be a reason why they lose central vision at an earlier age. And these patients respond really well to our anti-VEGF compounds. Here another patient of ours that you can see in the near infrared that typically that star-like autofluorescence pattern. Only choroideremia has it, and some differential diagnosis like autosomal dominant RP65 mutations, for instance. And here you can see how the MNV. All right, so to summarize, Francesco, you can go a bit faster. I don't want to. We've seen these different IRDs that can show M and V. You can see how diverse they can be and how important it is to do multimodal imaging in these patients, especially OCT angiography. And we all need to learn more about these cases because most certainly we do not have level 3 evidence on how to treat these patients, but certainly anti-VEGF is typically the first line choice. So thank you very much. Are there any questions?
Here also we have the problem to treat or not to treat, because when we treat we can induce an atrophy, when we not treat we can lose the eye, and during all the day this dilemma between to treat enough or to treat too much is still present. And so resume your attitude in this hereditodegenerative retinal diseases, how you choose to treat or not to treat.
I mean, you've summarized it yourself already really well. I think in these patients we need to do PRN treatment. They're not suitable for any virtual clinics, obviously. They're not suitable for AI, I guess. Not suitable for treat and extend. So these need to be, they need to be seen regularly. You need to do an injection and then decide case by case.
There is still indication of PRA treatment in ophthalmology.
You mean even of us as a doctor?
Hello everyone, it's Maurizio Battaglia Parodi speaking from the ophthalmology department of the Vita Salute San Raffaele in Milan. And I'm very grateful to our mutual friend Filippo for asking me to talk about macular neovascularization in dystrophies, giving me the opportunity to discuss with you about this special topic. As you remember, rarely inherited retinal dystrophies can be complicated by the development of macular neovascularization. And macular neovascularization in dystrophies are characterized by some typical findings. First of all, a slow growth, limited size, the location, more often macular neovascularization are subfoveal, limited symptoms, and scant exudative manifestation, meaning subretinal fluid, cyst or blood. In most of the cases, we deal with type 2 neovascular membrane. And overall, we know very little about the natural history, the evolution of macular neovascularization complicating dystrophies, especially regarding the visual acuity changes and the evolution toward fibrosis or atrophy. In addition, we don't know exactly which is the best test to monitor the changes in such cases. Macular neovascularization can complicate several dystrophies. First of all, patent dystrophy, and especially the adult onset foveal macular vitrecous dystrophy, requiring a differential diagnosis with respect to AMD, but other kind of inherited retinal dystrophy can be involved, including Best, Stargardt, leventinese, pigmentosa, and many others. Which kind of diagnostic option we have? Well, the mere biomicroscopy can be enough to suspect the existence of choroidal neovascularization. We better complete our examination, including fluorescein or endosynagric angiography, and OCT and also OCTA, which can be very useful for some cases of macular neovascularization. Treatment options include also observation. In many cases, we don't see a clear progression of the macular neovascularization with visual acuity impairment, so we better observe. but in the past we use also laser, PDT, and now anti-VEGF. Starting with macular neovascularization in pattern dystrophy, this was considered the most neovascular dystrophy, up to 15% of cases, and especially in the subform of adult onset foveal macular vitaliform dystrophy. OCTA can greatly contribute to the delineation of the macular neovascularization. The management is still not clear because some cases probably are stable, not require any kind of therapeutic option. More often we treat those patients with anti-VEGF, obtaining a resolution of the activity and a stabilization of the visual acuity with positive results up to 90% of cases over a follow-up of 12 to 24 months, according to the different cases. This is an example of a patient with pattern dystrophy, reticular pattern dystrophy. The leakage on the fluorescein angiography in the top of the figure show clearly the activity of the macular neovascularization. The patient was treated just with one injection of Avastin or bevacizumab, obtaining a stabilization of the condition with a limited but significant visual acuity improvement. Another example with reticular dystrophy, you can see the final result with the resolution of the fluid and also the fibrosis with, once again, a very limited number of injection and a visual acuity improvement. Macular neovascularization can also complicate the course of Stargardt, very rare condition, and we know that anti-VEGF can be beneficial. That means that we can stop the activity of the neovascularization, but we cannot improve vision, obviously, because of the pre-existing condition. We have some doubts about the possible worsening of the atrophy over the follow-up after anti-VEGF injection. This is a case with typical manifestation of the Stargardt disease, atrophic lesion flex, and OCT in the right eye show neovascularization with the typical hyperreflective lesion and some intraretinal cysts. The patient was treated with anti-VEGF injection. You can see that after 1 year there's an expansion of the atrophy and the CNV is still active with intraretinal fluid. This is the same case after 2 years, and once again CNV is still active, but you can comparing the different pictures, right eye and left eye, at baseline and after the treatment at the 24 months timeline. You can observe how large is the atrophy in the right eye, the eye receiving the treatment. So there's a suspect that anti-VEGF injection can stabilize the situation, but unfortunately may accelerate the development of atrophy, especially in the early phase, in the early course of the disease. That's another case with the comparison between baseline and 24 months follow-up. Once again, you can see an expansion of the atrophy, and this is another case with similar findings. Unfortunately, we have the suspect, the doubt that the treatment, even stopping the CNV, can be associated with a worsening, enlargement of the atrophy. This case series was published, just 3 patients, very rare condition, and as you can see, we found an expansion of the atrophy over the follow-up and a worsening of the visual acuity in spite of the treatment, because unfortunately there was the extension of the atrophic lesion. Number of injections is generally high, so With respect to pattern dystrophy, when 1, 2, 3 injections in most of the cases are necessary to stop the condition, here with Stargardt we need more injection. This is another condition which resembles Stargardt, and this is not Stargardt. This is the fluorescein angiography. You can see close to the fovea some leakage, fluorescein leakage, and this is a peripherynopathy, PRPH2 condition. The OCTA can clearly show the presence of the macular neovascularization close to the fovea, and just one injection of ranibizumab was enough to stop the evolution of the disease and to promote a complete recovery of the vision with 20/20 after 1 year. Even though we can obtain good results, we don't know exactly what's the natural history of macular neovascularization secondary to peripheral related conditions, and when the treatment is still necessary. Looking at this case, another case with variants in the periphery, and the identification, especially using OCTA, of a neovascularization. This is the picture after 1 year. So visual acuity was 20/20 before and 20/20 after a single injection of ranibizumab. The picture, the clinical picture after 1 year, looks like very stable with good results. But if we look at the OCTA, we can find that the macular neovascularization enlarged in a very significant way. So even though we don't see any intraretinal cyst, any subretinal fluid on OCT, we can observe the expansion, the growth of the macular neovascularization. Is this patient, is necessary a further treatment, or considering, bear in mind, visual acuity 20/20, the stable OCT picture, the patient can be simply observed over the follow-up. And what happens in the long run? Here you can see the evolution at 18 months with expansion, further expansion of the lesion at 24 months. So even though we don't have any sign on structural OCT of activity of the CNV tends to expand. So is treatment useful or not? The patient is asymptomatic, so we don't know everything about the management. Another special condition is the macular neovascularization associated with Best vitelliform macular dystrophy. Overall, especially in the past, the CNV rate was calculated to 10 to 20%, especially during the early stages. The management is unclear. In the past, PDT was used with beneficial results. Now we prefer inject patient with anti-VEGF with variable functional results, probably depending on the stage of the disease and the amount of atrophy of fibrosis. This is an example of a patient in the pseudopopian stage. Visual acuity is quite good, 20/25. There's the hemorrhagic exudation with expansion of the fluid, as you can see in the OCT and also in the color figure. Just one injection of ranibizumab with stabilization of the picture, and surprisingly visual acuity recovery 20/20 with stabilization over the follow-up. This is a CNV complicated the early stage of the disease, as well as in this case visual acuity 20/60. The development of the macular neovascularization with the leakage on fluorescein angiography in the middle row, and the single injection, in this case aflibercept, and stabilization of the picture with a good visual acuity recovery from 2100 to 2032. Even though we can see a worsening of the scar, visual acuity can be improved and can be retained. OCTA was very useful in the identification of macular neovascularization in Best vitelliform macular dystrophy. We know that the masking effect due to the vitelliform material deposition impairs the identification of the macular neovascularization using indocyanine granular fluorescein angiography. OCT is very useful, better delineating the neovascular net, and overall I think that we have two different subforms. Subforms typical of the early stages, meaning vitelliform obtrudipopion stage, in which we have exudative macular neovascularization visible in about 10 to 50% of cases, and another condition characterized by non-exudative macular neovascularization, more typical of the more advanced stage, especially vitelli-rapti stage, with variable figure from 60 to 90% of cases according to the subgroup of patients analyzed, the duration of the follow-up, the instruments we use, and also the skill of the ophthalmology in interpreting the results. I'd like to show you some recent data about the natural history of macular neovascularization associated with Best vitelliform macular dystrophy. We included 16 patients with a mean follow-up of almost 7 years, and 63% of eyes show macular neovascularization. As you can see, the mean age at baseline is is 30 years, so young adult. Over the follow-up, we registered visual acuity, foveal thickness, exudative manifestations. Well, as you can see, comparing the baseline visual acuity and the final visual acuity, there's no difference from 0.19 to 0.22. The same is true examining the central subfoveal thickness, 378 to 344, so no statistically significant change. Also, the area of the macular neovascularization is stable, and we didn't find any case of exudative manifestation, meaning evidence of blood or the exudate fluid. So, no substantial change over the follow-up in cases like that. This is an example of a patient examined in 2015 and 2025. As you can see, there are very tiny changes. The clinical picture are very, very similar. So, what's the management? Well, we know that macular neovascularization in vitelli-rapti stage doesn't bring about a visual acuity deterioration of or alteration at the level of the anatomical structure of the eye. So maybe this kind of macular neovascularization are useful for trophy support, and we don't need to treat this kind of patient, just observe patient, because we are afraid of promoting atrophy changes after anti-VEGF injection. Very rarely, macular neovascularization can also complicate retinitis pigmentosa, and we know for the minimum number of cases published that anti-VEGF can be beneficial from the anatomical point of view, reducing the exudation, but not from the functional point of view. So visual acuity won't be higher after the injection. And a typical manifestation of malattia leventinese, a disease our friends in Switzerland know very well, over the course of the follow-up is typical the development of macular neovascularization, as in the present case, even though the picture is very complex, combining atrophy, subretinal fibrosis, and also macular neovascularization, which in most of the cases are stable, and OCTA can contribute to the diagnosis. Very rarely, macular neovascularization can also complicate choroideremia. This is young patient. As you can see in the left eye, a large macular neovascularization with some degree of fibrosis and bleeding. The patient refused the treatment, and this is the OCTA. We can see how big was the macular neovascularization. Genetic tests were positive for variant in the GHM gene. Unfortunately, the patient refused the treatment, and so we don't know which kind of evolution the patient could have. In conclusion, the neovascular complication of inherited retinal dystrophy is rare, more frequent in Best vitelliform macular dystrophy, and maybe in malattia leventinese. The standard treatment now is based on anti-VEGF injection with variable final outcomes. Some patients not achieving a real functional improvement. So the management is still debate owing to our limited knowledge about the natural history. I thank you all for following this conversation, how to be of help. Bye bye. Thanks.